Good evening, everyone. Tonight we're going to do Lipids 101. That was the poll winner last week. I'll probably start doing those monthly, where I'll just kind of, after my monthly AMA, I'll just open it up to the top 4 things people are interested in, and the following week we'll do that one. So I actually think I'm going to continue these lipid chats because it seems to be pretty popular with the audience that's following me right now. So I'll do an ApoE one next week. So ApoE is very important for Alzheimer's. If you have an ApoE44 gene, really increases the risk of Alzheimer's, but it does have an effect on your lipids as well. So we'll chat about ApoE next week. So welcome everybody who's coming tonight. I see Dr. Hill join. Welcome. So tonight I'm going to be chatting more about just Lipids 101. So I've done a couple of different videos before, deep dives into lipids, but this is for people who haven't seen those. So this is kind of my general spiel I give my patients when they show up to apocardiology, and we go through an advanced lipid profile. So first start with what is cholesterol? Cholesterol is a waxy substance. It cannot float in your liquid blood by itself. Cholesterol is also not put into you to give you a heart attack by Mother Nature or God or whatever you believe in. Cholesterol is a vital nutrient that without it, you're not alive. You need your cholesterol to make your sex hormones. You need your cholesterol to make bile acids that digest your fats. You need cholesterol to make the cell membranes so that the cells stick together. So again, without cholesterol, you're not around. Now, where you don't want cholesterol is to be building up in the walls of the arteries. You got 60,000 miles of arteries that are providing oxygen and nutrients to all your tissues. So again, there's no good cholesterol, there's no bad cholesterol, there's just cholesterol. You just don't want cholesterol building up in the walls of your arteries, starving that tissue of oxygen and nutrients. But a better question sometimes should be asked is, how does that cholesterol get into the artery wall to begin with? Your arteries are not like sewer pipes and they just fill up 100% full of sludge and that gives you a heart attack. No, it's that the lipoproteins, which we're going to chat about tonight, they deposit that cholesterol payload into the wall of the artery. So 60,000 miles of blood vessels. Coating the blood vessels is something called the endothelium. That endothelium is 1 cell thick. The surface area of the endothelium, if you're able to take it out of the 60,000 miles of blood vessels, will cover the surface area of 6 tennis courts. So it's one of your largest secretory organs. One of the major things that it does is it releases nitric oxide, which is a signaling molecule, a gas. It does 2 things generally. One, it causes the artery wall, the muscle in the artery wall to relax, so that improves flow to the artery, so that keeps blood pressure down. But it also acts like non-stick surface, so whatever's floating through your bloodstream doesn't stick to the artery wall. If you have low nitric oxide, then the lipoproteins more likely stick to the artery wall like Velcro. So if you have endothelial dysfunction, you'll then have inflammation in the arterial wall, generally in the layer called the intima. The intima is the layer of artery that you measure when you do a carotid intimomedial thickness scan. If your intima is thickened, it means you have inflammation in the artery wall. That tends to mean that these lipoproteins are getting retained in the artery wall and causing your body's immune response to be activated. Your body basically thinks that it's being invaded by bacteria or viruses and sends out the warriors to go fight it. The monocytes and macrophages try to gobble this stuff up. So endothelial dysfunction, number 1. Number 2, inflammation response. But the lipoproteins is the main thing we're going to chat about tonight. So cholesterol, waxy, can't float in the blood by itself. The lipoproteins are generally made in the liver. The liver makes these spherical particles, these lipoproteins. In the office I show this tennis ball as an example for it. It's a cargo ship or a car. Fills up full of cholesterol, fills up full of triglycerides, which are essentially stored energy, and the main use of the lipoproteins is to transport that energy around, because the majority of cells can make their own supply of cholesterol. They're not requiring the liver to pump out cholesterol to them, but cholesterol is important as a structural compound inside the lipoprotein. But your muscles need a constant supply of energy, so 80% of your glucose is basically going to your muscles, and the lipoproteins are helping ferry the triglycerides, which is stored up energy. There's also fat-soluble vitamins inside these lipoproteins, vitamin A, D, E, and K, and there's things called phospholipids, which are building blocks for cells. So the liver makes these cargo ships or cars, pumps them out, sends them through your blood vessels. they're going to go to your liver. I'm sorry, they're leaving your liver and they're going to your muscle. So let's say your muscle cell needs energy. Your muscle cell is going to put out a little catcher's mitt, a little receptor, and it's going to bind to the lipoprotein, pull it in, and download what it needs. Then the muscle cell sends it back to the liver. The liver has to put out its little receptor, bind to it, get it down into the liver, puts it into the bile, puts it into your intestine, and you get rid of it. So there's generally 3 levers that you can work on when you want to modulate somebody's lipids if that person is high risk of cardiovascular events. So if somebody's already had a heart attack, a stroke, stent, bypass surgery, you're trying to prevent them from having a second event, you're going to be much more aggressive. Primary prevention, never had an event, maybe a little bit less aggressive with pharmaceuticals initially, but use the right tool for the job. And if the person has an abundance of these lipoproteins and it's not coming down with lifestyle changes, then you use the tool that works for that person. So hyperproduction, send less of these out of the liver. There's an issue in some people where they don't put receptors out very well on the liver to clear the blood. This is where the injectable medications, the PCSK9 inhibitors, can work. They basically prevent an enzyme that causes this receptor to degrade. It goes away for a bit, and the receptor just stays out longer. So you can clear more of these cargo ships or lipoproteins from the blood vessels. And then the third issue, in about 20% of cases, people are hyperabsorbers of sterols. So, the body's about to get rid of it from the GI system. A gate opens back up, says this stuff's still perfectly good, sends it through the portal circulation, sends it back to the liver, and now it's circulating around the system. So find out which lever you need to modulate and pull it down if you need to. But what you really want to look at, and I did it 2 weeks ago or so, was how to review an advanced lipid profile. Cholesterol, again, is not the boogeyman. And the traditional lipid panel, where you just have a total cholesterol, an LDL-C, which is usually calculated. Sometimes they do an LDL direct, an HDL-C, and a triglyceride. So the total cholesterol and LDL-C are not very predictive of risk unless they're excessively high. If you have a total cholesterol over 300 milligrams per deciliter and an LDL-C over 190 milligrams per deciliter, you potentially have familial hyperlipidemia, and you likely need treatment, but you should, again, test, don't guess, go look at what the health of the arteries are. So do you have endothelial dysfunction with an endopattern max pulse? Do you have thickening of your intima on a carotid intimal medial thickness test? Do you have calcifications in your coronary artery with a CT coronary calcium scan? Have you had a CT coronary angiogram? Or if you've had the newer test, the clearly scan, that would tell you as well if you have advanced plaque in your coronary arteries. So traditional lipid panel is useful to kind of point you towards if the person has a familial issue, and sometimes it'll point you towards, do you likely think they have a metabolic issue? So if they have very low HDL-C and a very high triglyceride, they may be insulin resistant, pre-diabetic. But the LDL-C by itself generally won't predict risk. This is a rough estimate, but in 80% of time it'll correlate with LDL-P or an ApoB, but in 20% of cases it won't. So why don't you check the actual particles or the cargo ships? So you can get an NMR test, which will check the LDL particles, which I routinely still do, but a test that might be even more sensitive than the LDL particle is the ApoB, or apolipoprotein B, which is a test that you can get on Quest, LabCorp, any of the advanced cardiovascular labs will offer it. Pretty standardized test, non-expensive test. Maybe it's $5, maybe it's $20. So even if insurance won't pay for it, it's worthwhile getting because it's the number one particle that determines atherosclerotic risk. So if you have endothelial dysfunction, you have inflammation, and you have the elevated levels of ApoB containing particles, you have the recipe to develop atherosclerosis or plaque in the arteries. So what is ApoB? It's a protein that sits on the outside of the lipoprotein. It has a couple different functions, but one of them is structural. So on a tennis ball, you can see the little white stripe on the tennis ball. That's essentially like the ApoB protein. It holds the thing into a sphere. Also acts somewhat like a lock and key. So when it goes to those receptors, the receptors will bind to that ApoB protein to get it out of the circulation. The ApoB is a protein made in the liver, and it's attached to a few different of the lipoproteins. It's going to be attached to the VLDLs, the IDLs, the LDLs, and the LP(a)s, if you have it, which 20% of the population has, lipoprotein(a). I'm not going to talk about the ApoB that's on the chylomicrons, the chylomicron remnants. Those aren't as important for atherosclerosis, and maybe we'll talk about those in a future chat. But it's the ApoB100 proteins that are on the outside of the VLDLs, the IDLs, the LDLs, and the LP(a)s, if you have it. But 90% of the ApoBs are on the outside of your LDL particle because they're the ones that have a longer half-life. You know, they may be sticking around in your system 1 to 2 days versus the VLDLs like 6 hours. So most of it by sheer volume is going to be stuck to your LDL particles. So you can monitor the ApoB level. You know, what is an optimal level? Well, it sort of depends on, have you already had an event? Do you have a lot of plaque on a non-invasive study? Normal is going to be somewhere likely less than 90, but if you've had an event, you probably want to be less than the 20th percentile. So, you want your level less than 80. But if you've had multiple events or you want to be very aggressive, you're probably wanting to be down less than the 5th percentile, and so you want your ApoB numbers to be, in the less than 60 range. That generally is going to require more than just lifestyle. It's going to take a combination of supplements and medications many times if that's what you're requiring. ApoB, simple test to get on a advanced lipid profile. It's the most atherogenic type particle when it's high enough. And so if you have, the analogy is too many cargo ships going through the riverways or too many cars on the highway, there's more shots that they're going to, have on goal at your artery wall. If the arteries aren't making very good nitric oxide levels, then these things tend to stick there. They get stuck there, get retained in the arteries. They mount an immune response. You build a fatty streak. You build a little plaque. It's like a little pimple on the wall of the artery. And if you don't shut that process down, the pimple ruptures or a volcano erupts. The blood clots. You don't have blood flow past the obstruction. Now you've had a heart attack. Now you have a stroke, depending where that plaque rupture happens. So the ApoB, number one atherogenic particle to get checked. If you have questions, happy to answer them tonight. And next week, we're going to chat about apolipoprotein E, which is something that is important to have checked at least once in your life. You get 1 copy from your mom, 1 copy from your dad. It's very important for cholesterol metabolism, but also very important for Alzheimer's risk, risk of diabetes. So next week, we're going to chat about apolipoprotein E. So I think somebody did throw in a question here, so let's see. So somebody says, they're not sure if it's linked to lipids, but they have a high blood pressure, and somebody who's 36 years old, supposedly linked to, quote, genetics. Can this be reduced naturally or without continuous medication, or will be need to manage through medication only? So it's going to depend on what the kind of resting blood pressures are. A kind of gold standard would be an ambulatory 24-hour blood pressure monitor to see what your average blood pressures are over the full day, as well as your dipping status. So does your blood pressure drop 15% while you sleep? That would be normal. If it's not dipping, or worse, it's rising, that's a big red flag. That's a recipe for sleep apnea, high cortisol, much higher risk of heart attack and stroke early in the morning if your blood pressure is not dropping appropriately while you sleep. So I can't answer without more context, but if you have high blood pressure, it's going to be partly because of low nitric oxide levels, so you got to figure out what's breaking nitric oxide production or clearance. But from the lipid standpoint, where they are tied is if you have high levels of oxidized LDL. Another test you can get is called oxidized phospholipid on ApoB. It's a more sensitive marker of the oxidation of the rusting of your lipoproteins. But if you have that modified lipoproteins, they will damage the glycocalyx. They will damage the gel coating lining that endothelium, and that will cause lower nitric oxide. So yes, it is cases where if people have significant oxidized phospholipids, you treat the oxidation, the lipoprotein ApoB containing particles come down, you should see the blood pressure normalize. And somebody's asking, what are some effective ways to lower ApoB? Again, it's going to depend on what's causing it to be elevated, but it is one of those cases where you want to do a little bit of detective work. So, not everybody's going to have a long history of ApoB, so you may have just a traditional lipid panel, and so you got to kind of go look back in the past. Did you have, quote, normal lipids at one point? Did you change something in your diet Did you go full keto? Did you go full carnivore and your lipids went abnormal? Well, then a advanced lipid profile may kind of guide you why that is happening. But if you're a hyper producer, which you can monitor on a Boston Heart panel of cholesterol, then you got to kind of attack it at the liver level. So that's where the statins, the fibrates, niacin, bergamot, the neuromedicines, bempedoic acid, nexletol, have an effect. There's a few other things I'm skipping over for brevity's sake, but those are the main common ones. If you have an issue with PCSK9, that's where the injectable Praluent or Repatha are working. There's a newer agent coming to market sometime this year. It's twice a year injection that will affect the PCSK9 enzyme directly to the liver, so you just keep these receptors out longer. And then again, in about 20% of the population, they're hyperabsorbers of sterols, and this is where ezetimibe, or used to be brand name Zetia, closes the gate, prevents the sterols from being reabsorbed. So those are the most effective ways to kind of address it, but you kind of have to do more advanced testing, figure out which of those levers that you really need to pull. All right, guys, well, I'm going to keep it short and sweet. Hope you learned something about ApoB containing particles tonight. If you have any questions, send me a comment as always. And next week, we're going to be chatting about ApoE. If you've had a 23andMe, if you've done advanced lipid testing, you may want to go back and look at your records and see if you know what your ApoE status is. There's going to be either an ApoE2, a 3, or a 4 on that test. And you want to see if you're a 2-2, a 2-3, a 3-3, which is most common, 3-4, or a 4-4. So next week, we'll chat about ApoE, Monday, 6 p.m. Central Time. So have a great week, guys. We'll see you then.